Hello, everyone. I would like to introduce you to one of the best personalities in chronic pain in India, Dr. Lakshmi Vyas. And we are very, very thankful that we have Madam here with us. She is a chronic pain consultant known all over India. She practices in Mumbai. And we have had the opportunity to get her on our platform today to ask her how is chronic pain as a career for anesthetists, and I would like to welcome you on behalf of all of us, ma'am. Thank you for joining us for the session today.
Thank you. Thank you for inviting me. And it's a pleasure always to speak to youngsters because someone said, if you wish to remain young, you need to be in the company of youngsters. So I'm following that.
Thank you, ma'am. And ma'am, as chronic pain is an upcoming career path now, however, there isn't much information about it unless you delve into it. So we wanted to know from you, how was your journey? How did you start? How did you know about chronic pain? And how did you move on in your career as a chronic pain consultant?
See, I came from pediatric anesthesia. And I was a pediatric anesthetist at Wadia Children's Hospital. I had no intention of leaving pediatric anesthesia, so I didn't even think of chronic pain. But then, as I was telling you, life takes you where you need to be. So circumstances played out in such a way that I had to leave Wadia. So then private practice was something very easy for me in anesthesia. But unfortunately, I was not very happy because the academic bug had bitten me. You know, I wanted to do clinical research, I wanted to teach and all those things. So then pain was one of the choices. And more than anybody, in fact, it was my husband who was always telling me that you should be a pain specialist because, anesthesia is a dependent branch. You should be your own person. So you should go for chronic pain. I said, chronic pain, there is no teaching in India at that time. I'm talking about 2002. So there was nothing like any formal teaching. And there were no pain clinics. Dureja used to do something in AIMS, but that was as a very, very part-time thing. Because as an anesthetist, your primary attention goes to anesthesia and you also do pain.
Yes.
So that was about the only center, I think, doing some kind of work, but not really full-time work. So I said, I can't suddenly start off pain. I'm not a specialist. Then he said, look, you need to teach yourself pain. Go abroad, see the pain clinics abroad and come back. So anyway, that is what I did finally. I took off. I was very nervous, I can tell you. Because you see, as a pediatric anesthetist, I was on top. I was one of the very few pediatric anesthetists in the country. I was the person who started regional anesthesia in Wadia Children's. So you see, you are at a particular level. And suddenly to go into pain, I was less than zero in pain. So I was very hesitant about this. So I said, okay, the best thing to do is to really read up and study. I took a sabbatical for a year, gave up my private practice, sat at home for a year, and I read all the possible pain management books that were available. Then that left me no wiser, I can tell you. And then I said, okay, let me go abroad and see the pain clinics to see the practical work. So I went to US, I went to UK, then I went to Japan also, I went to Singapore. So after seeing all these pain clinics, I had some kind of an idea. And everywhere I went, I saw spine. I said, okay, so that means I need to understand spine. I need to go to a spine surgeon and learn what what all this spine pain is about.
Hmm.
So I came back to India, went and I think I did something like an internship with Dr. Ingal Halikar, who runs a back pain pain school in back school rather in Thane, and he's a very generous teacher. So not only did he teach me about pain, he taught me all about orthopedic pains, how to deal with them, how they deal with it. He gave me the orthopedic viewpoint, and then I sort of developed my own viewpoints on those things. And then I said, I don't even know what the black and white shadows on an MRI are saying. So I went to an MRI center in Jaslok, and I said, please teach me what it is that you are deciphering on these. So I learned that. And so it was like I picked and chose whatever I thought I had to learn. And I learned. And then, of course, I jumped off at the deep end and started. I thought that since I was a pediatric regional anesthetist, I thought that was a very big qualification for me to be a pain specialist. I discovered otherwise later, but that's a different issue. And so I started off. And then this is about how I came into pain management. What happened thereafter, maybe you'll ask me what happened there. Yeah.
Okay. Wow, ma'am, that is a very inspirational journey. You have actually gone to the grassroots level and tried to, put the pieces together, and now the puzzle fits, and that's why you've become such a well-known and successful pain consultant. But ma'am, I would like to ask you very honestly, what is the scope of pain clinics in India? Like, if we see in an urban place like Mumbai, maybe we have organized pain clinics, but if I have colleagues in two-tier cities who are now PG residents and want to practice, for example, if they want to go to a small place like Dehradun, so is there anything where they will know, I mean, the patients will know that, if we have pain, we have to go to a pain clinic, or does it get lost in translation in hospitals and it never referred to a special pain consultant as such?
Pain is something which everybody has treated, right from a family physician to an orthopedic surgeon, a neurologist, every specialist, every doctor treats pain. But nobody treats pain. Do you get what I'm saying? They
Yes.
don't really look at pain. They just sort of do something for it and dismiss it. So they don't really treat pain. They don't really want to know about pain. So it is a very cursory kind of treatment. And they just say, okay, refer to physiotherapist. Yes. So you outsource the whole thing to a physiotherapist. You write a few analgesics and that's it. So frankly, pain has been the orphan child of medical science. What gave rise to medicine is pain. That's the oldest symptom. It's because of pain that medicine is born actually today. But somewhere along the line, pain lost its importance and people took up, let's look at what causes pain. That became more important than the pain. And as a result, nobody knows pain and everybody treats pain. And because they believe they have treated pain, there is a familiarity with it and a dismissiveness towards it. But so when coming to your question of how do we get the patients?
Yes. Is there a scope that you can have this as your sole career
Yes.
without being an anesthetist alongside, or doing some cases, freelancing, and then running a pain clinic? Like, can you just do sole pain as your career lifelong?
I started out that way.
Okay.
That I said, I cannot ride two horses. I don't know. See, I was very nervous. I thought I didn't know anything in chronic pain. So I said, I don't want to ride two horses. So I want to focus on pain. So I gave up anesthesia totally. It was a very voluntary decision. I loved anesthesia. I enjoyed pediatric anesthesia, but I made a conscious decision to not to do any more anesthesia because I'm taking on something like chronic pain, which is a very serious matter. So I gave it up. I gave up anesthesia and I started. That probably would not be a very good option for a breadwinner of a family. I was not the breadwinner of my family, and I could afford to, financially, I could afford to indulge myself in focusing on what I chose to. So, for the youngsters who want to do it today, I think initially, till they get known as a pain specialist, they might have to depend on anesthesia and for generating money, and also to let people know that you are doing pain management. You see, anesthetists are usually quite talkative people, and also surgeons listen to them. That's a captive audience after all. You have given anesthesia and he or she is operating, so they listen. So you see, they get to know that you are doing this work, that work, etc. So that's a very subtle public relation exercise which goes on.
Advertising yourself.
And at the same time, you are earning some money and you have to focus on the pain management. I believe that is what has to be done. This is contrary to what I started out. When I started, when somebody came to me to learn, I would say you cannot do anesthesia because you cannot really give the attention to pain that it deserves. Yes. But later I realized it is not a very realistic
to start off with.
Not lucrative. It's not a realistic option because you see, money is a very important aspect of life. And you see, I started out with certain advantages. I was a teacher in pediatric anesthesia. So there are a lot of anesthetists knew me across the country. And also, as a result, when I started, there were a lot of cases which would come to me because the anesthetists would tell their surgeons, it's the surgeons who have the pain patients. So when they say, "Arey, aisa patient hai, kya karu main?" Then they'll say, "Madam has started pain management, send it to her." What does she do? We don't know what she does, but she'll do something to it. So that kind of a referral started for me automatically. So that is that's not the common scenario.
Okay.
So my practice took off because of anesthetists, my anesthetist friends, I will say. And I was getting referrals from people whom I had not seen, never heard of, but it started. And that was a great thing because I could, it gave me a lot of, what shall I say, pain conditions to explore, which I would not have done otherwise. The number of referrals were quite a number. But then now, when a new pain specialist starts, they are not going to start with these advantages. They are youngsters and they are not known for their anesthesia skills, let alone for their pain skills. So they will have to do this way, that for some time they have to keep anesthesia as a public relation exercise, as a financial support, but focus a lot on pain, in the sense in the studying and other things. So that brings me to the other aspect of pain. You see, everything in medicine is a limited subject. Because if you take anesthesia is one limited subject. And if you take surgery, general surgery, a general surgeon won't know plastic surgery. I'm sure if he becomes an adventurous and starts doing some plastic surgery, it's the anesthetist who will guide him, because anesthetist works with plastic surgeon and general surgeon. So
Yes.
like that, you see, every branch is very limited.
Hmm.
Orthopedic surgeon knows orthopedic surgery, general surgeon knows general surgery, neurologist knows neurology. It's very compartmentalized.
Hmm.
Whereas come into chronic pain, you get patients from all specialties. In my clinic, I might start with a back pain patient. I might go to a urology pain, then
Hmm.
go to migraine, then go to something else.
Hmm.
You know, it's like every single branch of medicine gets represented in the pain clinic. So
Hmm.
it's a very vast subject. And
Hmm.
if you have to do justice to your patients, you need to understand what it is that is causing the pain.
Yes.
Only then you can treat. It's
Hmm.
not about what nerve blocks you can do, but
Hmm.
you have to know what is the pain generator, what are the mechanics of that pain if you really wish to treat the pain.
Hmm.
And believe you me, it's a very, very complex and uh, it's a whole new world out there. So
Hmm.
which I did not know, and I had to learn over the years when I started.
Hmm.
So a lot of studying and learning has to be done.
Hmm.
So though you will do anesthesia, you have to be very clear that that is only the for the bread and butter.
Yeah.
But you have to, your mind, attention, passion, everything has to go towards pain if you wish to be a pain specialist.
That is
Yeah.
very well put, ma'am. My next question to you is, can you describe your day as a chronic pain consultant? Like a typical day, how many hours do you spend in the OPD, interventions? So like typically.
See, I have a pain clinic of my own.
Hmm.
So I have the OT in the place or in my premises. I have treatment rooms. It's a nursing home, basically, though it's a daycare center.
Okay.
It's about, 1,400 square feet area. So
Hmm.
that gives me enough number of rooms as well as a good OT and all that. So what I do is I keep seeing patients,
Oh,
and in between I do interventions.
okay.
And I also have people, fellows who are working with me. So they do a lot of work by
Okay.
way of preparing the patient, taking a history of a patient, and all those things. So, which if I was alone,
Hmm.
which a new person would be,
Hmm.
then it would have to be probably OPD on one day and interventions on another day. So, you should do your OPD, you sort of decide what it is that the patient needs and decide what is your plan of action, what is this pain, what needs to be done. You have to explain to the patient, I want to mention this here, that in pain, history taking itself will take about 20 minutes to half an hour to 1.5 hours, depending on how complex the pain is and how long the history is and how many doctors this patient has met before he or she comes to you. So it's a very long history which has to be taken and documented. Very important to document because most patients have very short memories.
Hmm.
They will come crying. They will say 10 on 10 pain, I can't stand, I can't walk, I can't do this, etc.
Hmm.
But then later, after they are all right, they'll tell you, no, 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 I didn't have much pain when I came to you. I was all right. So you need to document. You need to document the history. You need to document it. We document even the still and video pictures so that the
Okay.
patient, we tell them, look, this is the way you were walking and
Yeah.
see you're walking today. So because they have a very selective memory and a very short memory. So
Yes.
it's better to document. You have to document.
Okay.
Otherwise, you will be taken for a nice, good firki by the patients.
Okay.
You need to document. And then after that, you'll need to ask for certain investigations as and when needed. And then you post them for an intervention. And most of do you want me to go into the interventional part now?
Yes, ma'am.
Or you want to ask some other question before
No,
that?
ma'am, you can go into the interventional part.
See, most of pain management, you can say, is divided into 3, 4 main parts. One is you, of course, the history taking. And then after that, how do you manage it? Management will depend on the medical management, conservative management. And then, of course, one of the very important aspects of pain management is physiotherapy and referral to physiotherapy. And this is something which all pain specialists should make it their business to understand physiotherapy very well. If necessary, spend some time learning physiotherapy so that you know what they are doing. You need not do it, but you should know what is being targeted and why. And then after that comes the milder interventions, non-invasive interventions like the physiotherapy modalities and other things. Then comes the interventions per se. The interventions, most of the time, which are available today in most chronic pain management setups, is they target the nerves.
Yes.
Most interventions are neural. This is because of the definition of neuropathic pain as something that addresses the somatosensory nervous system. So because of this, all the interventions will address the somatosensory nervous system or the sympathetic nervous system. So it's either sympathetic ganglia or the peripheral nerves, the somatic nerves, the nerve plexuses, etc. And in back, of course, you go for the transforaminal epidural and facet injections and all those procedures. And most of the time, the muscles are outsourced to the physiotherapist. Most pain specialists will do the interventions and then say, okay, now you need to strengthen yourself or you need to stretch or whatever it is and refer to physiotherapist. This is a working model developed by orthopedic surgeons. Orthopedic surgeons will write painkillers and say refer to physiotherapists. Pain specialists will write medications, do interventions, and say refer to physiotherapist. But that is where the whole of pain management, in my opinion, has taken the road which is not very, what shall I say, advantageous to the patient or to themselves. From the beginning, I started with this model of doing interventions, whether it is fluoro-guided interventions or ultrasound-guided interventions or whatever it was. Use a nerve stimulator or whatever to do the the intervention, and then refer to physiotherapist. Then I found that all my patients are doing very well, maybe for a week, 10 days, 1 month, whatever it is. And then they are back in my clinic like a bad penny. They'll say, doctor, we were doing very well, but I just did this and my pains are back. So, I had seen this even in when I visited the pain clinics abroad. And so I said, no, you might not have done this physiotherapy or whatever it is. But I was not very happy with this kind of a situation. I said, this is something very wrong. They have done an intervention in all good faith. And I have done it in all very good faith with the correct way, look with a fluoroscope, etc., expending all my expertise. And at the end of it, if this wonderful block is going to last only 1 month or 2 months or 3 months at the most, I don't think it's worth it. It should not. If I went to somebody as a patient, I have come to you for a good relief. I have not come to you for 1 month relief or 2 months relief. So then I said, what is it that I can do to prolong this relief? That is where my real journey in pain management started. This was somewhere around 2004-05. That is when I started asking myself all these very awkward questions. What is it that we are missing? What is the missing link in this chronic pain? Then, it was a very fortuitous meeting with Dr. Chan Gun, who, who is a pioneer in dry needling. So he taught me dry needling. He calls it IMS. I learned it. And then after coming back, I'm a doubting Thomas. When he taught me and he sang praises of dry needling, I said, okay. I took it with a pinch of salt. I said, okay, this old man is very keen on that. Maybe that's what he is good at. That's why he's saying about this. So I came back and very skeptically started trying about dry needling. And then I found that the results were suddenly going up. The patient who has come back to me with, after an intervention, saying that he's got pain, is suddenly much better. So I said, what's going on here? What is it that we are missing? So, see, most textbooks sweep muscles under the carpet. As you know, it's an also ran kind of a thing. Every single textbook will mention muscle as a pain generator, but that's about it. They mention it, but they don't do anything about it. So, but I started doing this dry needling. So then I found that 1 + 1 becomes 11 straight away. So I said, okay, I need to understand why. And so I realized that I didn't know much about muscles. So I went back to anatomy. And when I went back to anatomy, I said, okay, I thought, you see, I was very arrogant. I thought I know anatomy. So I'll take about 15 days to learn muscle anatomy. And believe you me, at the end of 15 days, what I knew was I knew nothing at all. So then I said, okay, better now come down from my high horse and learn. And I did about 6 to 8 months of dissection to understand muscle anatomy.
Wow.
With understanding of muscle anatomy, I realized that opened a whole new world of understanding about chronic pains. So that is, and my dry needling techniques became very accurate.
Okay.
And with accuracy of dry needling, my results became better and better and better. So you see, I had patients who did well, continued to do well, and they were obviously grateful. So, of course, I enjoyed this, but I didn't know what exactly was happening here. Why addressing muscle gave this kind of results. As I worked more and more, I realized that most of the prevalent theories of chronic pain are not really relevant. They have been put up by people who had no interest in chronic pain. They have been put up by orthopedic surgeons, neurologists, who looked at pain from their peripheral vision. They didn't look at it, focus and look at it. So that was the reason why they focused on nerve blocks. And the anesthetists are the inheritors. They were the ones who knew how to use opioids. They knew how to do nerve blocks. So they became de facto pain physicians, though they didn't know anything about chronic pain. They are experts in acute pain. Acute pain is a joke to you. If I were to ask you to treat acute pain of any type, you can treat it without even thinking. Whereas chronic pain is a very different animal. It's a very, very different situation because chronic pain involves the mind. It involves the nervous system. It involves the spinal sensitization, central sensitization, peripheral sensitization. And all these are very, very real facts which are there in every single patient. And all the words which all of you find very, bothersome: allodynia, hyperesthesia, hyperpathia, hyperalgesia, all these you find in every single patient of chronic pain. So that is where I took the road not taken and I went off on a tangent. See, I was senior enough to believe what I saw. I didn't have to, please the what shall I say, prevalent understanding, the high priests of prevalent understanding of pain. I didn't have to please them. The person I had to please was my patient. So my patients taught me today what I practice. And that is a very different, what shall I say, understanding of chronic pain that we practice in my clinic, and people who practice with me also see on a daily basis the results. And also it has led me to develop a lot of new treatments for very different pains. It's been a fantastic and very absorbing ride from in the last 20 years. I don't think I would have stayed in chronic pain if it was not so fascinating. I would have said, okay, enough. Okay, I've done about 5 years of chronic pain. Enough. I can retire. But it has been so fascinating, and it has now become a responsibility for me to share what I have discovered, so that you see, the patients deserve it.
Yes,
The
absolutely.
patients are the ones who need the relief. And can we provide it for them? 100%. Pain. Now, let me come back to your original question. Is it a good career opportunity? Yes, it is a fantastic career opportunity. You make a definite difference to someone's life. And most anesthetists are very cerebral people. Not only are you very handy with doing procedures or whatever it is, but at the same time, you're thinkers too. You're acute pain physicians. So, you see, we are ideally suited for this job. And if we pay the attention that chronic pain deserves, it is fascinating intellectually. It is, what shall I say, very rewarding financially also. See, I have dedicated almost 60-70% of my practice to learning things.
Yes.
And teaching. I have not practiced on developing a practice. I have never thought that I should have some 2 franchises or 10 franchises with so many pain clinics across the city, across the country, etc. Had I wanted to, it is possible. When you're producing results, it's very easy to do that. But to me, the lure of understanding what is this pain, doing clinical research, publishing papers about it, and teaching and sharing with the younger people what this is all about, that was more fascinating to me. In spite of this lackadaisical approach to earning money, I have managed to do quite well. I'm doing well, I can say that. So, for a youngster, definitely financially they will do well. They may take a year or two when they need to take the support of, anesthesia earnings. But after that, they'll do very well. And in the tier 2 cities, they will do better than in Mumbai. Because Mumbai is a place where you are in a ivory tower. You're sitting somewhere. Unless somebody refers the patient to you, the patient will come to you. Whereas in a small city, someone knows you, somebody else is a friend of yours. So somebody will come to you. And then once you produce result in one patient, that patient will be so grateful. They will bring more patients. In fact, most of my practice, I would say about 70% of my practice today is because of patients bringing patients.
Word of mouth publicity.
Word of mouth, and maybe about 20% is other doctors referring. So it is this ripple effect which comes in every pain specialist, this will come. And this is the ripple effect that we should look for. So that you see, nobody is interested in referring cases to you. No surgeon, no physician. They want to treat their patients.
Yes.
Not looking for whom shall I refer this patient to.
Yes.
unless it's a family physician with other interests.
Hmm.
But other than that, nobody is looking to refer patients to you. And so this producing results and the patients bringing patients will sustain your practice. And this kind of a practice is more easier to establish in a tier 2 city.
Okay.
In fact, I always look for people from smaller towns as my fellows.
Okay.
Because I feel that they make a big difference.
Yes.
You see, the patients should not have to travel to big cities for treatments. Everything is treatable at a smaller city and other things. And the practice that I have developed achieves results with very simple equipments. The only sophisticated equipment I need is an ultrasound.
Okay.
Ultrasound, if you take away my ultrasound, I think I'll find it very difficult to practice.
And ma'am, I guess CM also.
CM, yes. CM, yes, you do need. But if you take away my ultrasound, it would be very difficult for me to do practice, because my main treatment modality is ultrasound guided dry needling, ultrasound guided Botox, ultrasound guided nerve blocks. So everything is ultrasound guided, ultrasound guided. And you should not be doing blind blocks. You should not be doing blind needling. And because you have to produce results.
Yes.
In chronic pain, the patient comes to you. You are the last port of call for them. They've got to 6 other doctors or 10 other doctors or 60 other doctors before they come to you. So they are in a very despondent situation. They are in pain. They don't want to go wandering again. They want to find answers. And when you do an intervention or dry needling or whatever it is, it has to hit the pain generator properly, accurately. And that you can do only if you have, visible proof of where you are going and what you are doing. That's very, very important. So blind blocks, people may be very good at it, but that won't suffice when it comes to chronic pain.
So, ma'am, picking up from some of the points that you mentioned, how do you feel about other specialties encroaching on pain? Like we have orthopedic surgeons, we have radiologists who have also jumped into the entire, pain. I would say they call it as a pain industry now. So, how does an anesthetist, as you said, we are very good as acute pain physicians, but as chronic pain physician, how do you create your own path amongst all of these? So what would you like to say about that?
Why do you think they are encroaching? Aren't you encroaching?
But we are responsible for taking care of patients' pain perioperatively, not like.
Chronic pain is a very different animal.
Yeah.
So it's okay. Let them do their practice. Orthopedic surgeons have been traditionally the people to whom patients go. But it doesn't matter who the patient goes to. Ultimately, they land up with you. Because if you provide answers, they will land up with you.
Yes.
So the youngsters who are listening have to focus on producing results, establishing a reputation. Don't focus on establishing a practice. Don't be in a rush to do, to be known as the pain specialist anywhere. What you focus on is to produce the best result that you can, because chronic pain patients deserve it. Believe you me, they are some of the most, they have suffered a lot. So they deserve your best. So you focus on providing the best for them. Then the rest will take care of itself. It may take a little longer. It may take, if you are lucky, if all the stars auspiciously come into their place, you may get your practice going like a bang. But that's not the important thing. The important thing is you produce results and wait. And while you're waiting, take the support of anesthesia. That's not a problem.
Okay. So, ma'am, that brings me to the next question. Like you said that when you started out learning about pain, there were no organized programs as such for people to follow, and that's why you had to put in a lot of efforts, and you had to, be a self-taught person in the initial part, go and attend pain clinics. But now it has become, the opposite. It's become more of a confused, chaotic situation where there are multiple pain fellowships, there are programs, and everyone's confused as to how they should. We have programs which actually go from 2 weeks to 3 years. So if I was a PG student who is just passing out of my residency, what would your advice be as to if I want to learn chronic pain? Where should I go? How much time should I spend learning it? And what are the aspects that should be covered? Something about guiding someone who wants to take up chronic pain as a career in the academic part of it.
In the first 5 years of my teaching in chronic pain, I used to say introduction to chronic pain. I used to do a course for about 10 days. And then I found that people don't have patience for 10 days. They want it for 1 week. And then they wanted it for 3 days. So everybody wishes to learn everything about chronic pain with probably they want it done yesterday, today. So that is not going to work. Chronic pain is the problem which has stumped the best of minds all these years. You cannot hope to learn it in 1 week, 10 days, 15 days, 1 month, etc. You can get an introduction to chronic pain if you go and do some kind of an internship in a pain clinic for a month or 2-3 months. You do understand some things in 3 months, but 1 month, I really do not know how much they will learn, because the whole concept is very different from what you know as an acute pain specialist. In fact, you have to do your homework first and then go to a pain clinic. And then when you read a book on chronic pain, it sounds all very boring, actually. When you talk about, spinal sensitization or peripheral sensitization, or this pain, the behavior of this pain, that pain, etc. These are all things you have never seen. So it's very boring to you. It's only when you go and see them in a pain clinic that it makes sense to you. So it has to be a learning on one side and seeing in a pain clinic as the other aspect. So to me, at least 1 year is necessary if you want to have some kind of an understanding of pain. And then 3 years is a great idea. 3 years is a great idea. And I think there are a few centers which are offering this. But 1 year fellowship is, I think, fair enough. The people who have trained with me, they are doing quite well. See, it doesn't mean that you stop studying at the end of 1 year. You have been equipped with certain skills in that 1 year, certain ways of thought processes in that 1 year. You have to go forth and apply it in your life. If you do that, it's a continuous learning process.
Yes.
See, chronic pain is a great teacher. And I'm still learning. You see, today, when I see some patient, I don't know anything about that kind of a problem. And the patient is sitting in front of me. I've got to do something. I've got to figure out something about it. So it's a very sort of intense learning which goes on. So after 1 year, you continue to learn. And you see, today there are enough pain specialists, senior pain specialists around. So you can choose your mentor and discuss with them. And I provide this facility to all the people who have trained with me, that they can pick up their phone and call me and discuss any case with me. And I'll tell them, yes, this is this way, that way. So you see 20 years of experience versus 2 years. There is
Yes.
always going to be a different weightage.
Yes.
Once you get that input from the senior person, so then you go apply it. So that makes life easier for the junior person who's approaching pain. And then when they do something and produce results, it becomes very solidified. That knowledge which is given by the senior person, you see it work.
Yes.
So then it's like it forms a layer in your learning then. So that is the way it has to go on.
Okay.
So in that 1 year when they are with us in a fellowship, they have to understand how to work this one fluoroscope, how to be very familiar with all the different views, how to place a needle under a fluoroscope, etc. And also how to read an X-ray, how to read an MRI, how to diagnose, how to diagnose. See, anesthetists are skilled people.
Hmm.
They know how to do blocks. And to them, you give the facility like ultrasound or a fluoroscopy. You are getting vision to do whatever you are doing. So
Yes.
doing blocks is not a problem.
Hmm.
Doing blocks is a joke. But, or even let us say placing a, let's say something like a spinal cord stimulator in the epidural space. It's an anesthetist can learn very quickly. It's just a different way of placing a needle. It's just a different way of passing a catheter, etc. But within a very short time, they can learn it. But the important thing is, where do you do it? Why do you do it? Do you do it at all?
Yes.
Those are the important things. Doing the procedure is not important. The procedure is something which you've got to learn. There is no other go about it. But when do you do? How do you do? Why do you do? Why do you do is the most important thing. That is where a lot of time will go. And that is where most goof ups happen.
Okay. So actually, this reminds me of something that my husband was told when he was doing his surgical residency. He was told that you should not be learning how to operate. You should be learning when not to operate the patient.
Exactly. Exactly.
So it's something
So
very.
it has to be like that because you should know why you are doing what you are doing and when you should do it. And you see, it's a partnership with your patient. You will have to discuss sometimes. Look, I believe this much of your pain is coming from your muscles, this much is coming from your nerves. I believe that this is the correct treatment for you. But this, you tell me what you want. Because many patients will tell me, I don't want a spinal injection. My spinal cord, I don't want a needle going into my spinal cord. Fair enough. Then there is another way of dealing with it. See, that is where you see this dry needling becomes so useful, where we have an alternative. And then I will bargain with the patient. Okay, we'll try to relieve your pain. But if you find that the pain does not go away for good, or it goes away but tries to come back, then you have to accept an injection in your spine.
Yes.
Then there is the other category of people. Doctors, steroid injection, we don't want steroid injections. So, you see, you have to sort of educate them also. And educating patients is not a very big problem because, very, very simple, completely uneducated people can grasp the nitty-gritty of the complexity of chronic pain. If you explain to them the right way, they understand it, they grasp it, and they cooperate with you for the treatment. So we need to, this is a skill which anesthetists have to develop. This is not a skill which they have. Most of the time, you have a patient who shuts up the moment you see them. You're knocking them out. So you never discuss things with patients. Whereas in chronic pain, you have to discuss. And you have to, after you've treated, you've got to get their feedback, you have to get their Sometimes patients will tell me, maybe this is the problem, doctor, we should do this. I'll say, yeah, let's do that.
Yes.
So it's a lot of give and take with patients. Yeah.
Ma'am, could you give us a small overview about your fellowship? Because everyone on the platform has requested for that. Yours is one of the best fellowships that we have in India now. So we wanted a little bit of an introduction to it. Like, what do your fellows do? And
Yeah, this fellowship is a 1-year fellowship. It is through the MUHS,
yes,
and MUHS does the selection. I don't select my fellows,
yes.
unfortunately. I have to take whoever comes to me.
Yes.
So that is the way it
The
is.
selection, just for the people watching it, is based on a lot of things, including if you're a domicile of Maharashtra, what were your marks in 12th standard, what were your marks in final year of MBBS, and there are a lot of tiebreakers, even regards to your age, which will and the choices that you fill, and all those are computed, and a fellowship is allotted to you. So sorry, ma'am. Sorry for cutting.
No, that's fine. I'm also not very familiar with all these.
Yes.
I just accept the students when they come to me. I don't look into all this,
Yes.
thankfully. And they come to me, and when they come, so the first 1 month is lost in bemusement for the new fellows. They have no clue what is going on. They think they have come here to learn nerve blocks, how to do this block, that block, etc. And they are seeing me flit from room to room doing some ultrasound guided dry needling, which one of the surprising things that I see is many of them are not really very comfortable with ultrasound. They have trained in institutions where there are ultrasound machines, especially post-COVID. I think every department is full of equipments.
Yes.
But what I find is that they have not really spent time familiarizing the hand-eye skills which are needed to work with an ultrasound and other things. But that's okay. That will change, I suppose, with batch to batch and the personal inclination of the person and all that. So they say first month is spent in bemusement. How it happens is the senior fellow who has spent about 6 months or 1 year with me, they will be taking the history and they will be coming and telling me the history. And then the juniors will listen to how the history is taken, what are all the questions that are asked. There is a proper form. They don't have to remember what question to ask next. It is there in a paper and they have to ask those questions. In a pain, where is your pain? Please mark it on a pain diagram. And that marking is very, very important. As I told you, the patient will say, I've never had pain there. Then we have to show them, you have marked it here. So it's you marking, it was there.
Yeah.
So how to mark things on a pain diagram, what aggravates pain, what reduces the pain, and then what are very, very important factor, what are the limitations? How long can you stand? How long can you sit? And how long can you walk? How many stairs can you climb? These are the daily activity limitations which we document. These are very important in back pain and other things. And then if they come with something like a complex regional pain syndrome of the hand or a neuropathic pain of the hand, then there are other parameters that you have to look at. What can you do with that hand? What can you not do with that hand? And then again, similar scale is there for the leg also. So depending on where the pain is. So it's a very different way of looking at history and documenting it. And then we also ask for vitamin deficiencies. Are they there or not? See, vitamin deficiencies play a very huge role in chronic pain because, if you have vitamin B12 deficiency, You can have, it's responsible for the myelination. So you get short circuiting and a lot of irritable nerves if you don't have adequate vitamin B12. And then if you don't have adequate D3, D3, the best known anti-inflammatory. So if that is not adequate, then you will have problems. So all these things are asked for. We ask for these blood tests and other things. And then we make a tentative diagnosis, clinical diagnosis. Then I'll say, okay, let us look at the MRI or ask for a new MRI to be made. Or if it is a knee joint patient, I'll say, let's get an X-ray done. Or if it is a shoulder, get a X-ray done, or whatever it is. Or maybe send him for an ultrasound, diagnostic ultrasound, or whatever it is. So we ask for the investigation. And then we plan what treatment should be done. And then I'll discuss the case with them, saying that what treatment should be done. I will quiz the senior fellow. What do you think you want to do? So they answer. So the juniors will listen to what the senior fellow is saying. So they learn also. And then I will say, then I will sort of sum up the whole thing saying that this treatment is done because of this condition. And this is done to address this kind of pain. And then they start seeing the treatments being done for the patient. So, and they will document. When the patient has had an injection, let's say, and then when the patient comes 5 days later, the history follow-up is taken. Okay, Mr. So-and-so, you had this much limitation. You could walk only 2 minutes. How much are you walking today? How much is your pain today, etc. So they learn how to document all these things and also how to understand it and then interpret what they are finding. That is what has to be understood. And then this is written. All follow-ups are written. They have to be written. And then we do the next treatment. So they see the progression of the pain relief.
Yes.
How much pain relief came because of a nerve block? How much pain relief comes because of the ultrasound guided dry needling? And then how much pain relief comes because of a physiotherapy? Like some patients will say, doctor, your pain block was absolutely useless. I've had no relief. Then we'll say, okay, no problem. Sit and now just do physiotherapy. Then after physiotherapy, then the patient may say, hey, my pain is gone.
Yeah.
They needed this.
Yeah, it has augmented your treatment actually.
Yeah. It has to be understood that there are many ways of skinning a cat.
Yes.
It's not just your block,
Yes.
which is important. Everything contributes to all these things. So, and the patient also understands what relieved them. And the new junior person understands what's happening.
Okay.
But as I said, first 1 month, 2 months is lost in bemusement. As to what is happening. It's going to be difficult for them because this is not anesthesia, which they are familiar with. This is a very different specialty. So, but as the time goes on, they start taking the history. After maybe a month or so, they start doing the history. And then, of course, it will be critiqued. And they will also see procedures, how to focus the fluoroscope, how exactly you should look for the transforaminal epidural, how it should be done, how does a facet look, how do you put a needle, how do you guide a needle under fluoroscope, etc. All this they see every day almost with whatever procedures are there. See, and we get various kinds of procedures. So one day they may see a knee procedure, one day they'll see a back procedure, another day they may see a shoulder procedure, and they may look at, something like a growth factor injection, or they may look at a pulsed radio frequency, or they may look at radio frequency procedure, or they may look at a test dose. There are so many procedures which are done. So they get slowly introduced to one procedure after another. And then there are theory classes about fluoroscopy, what they are supposed to do with the fluoroscope. Then there is also theory classes on ultrasound. Then each condition, then we have, you see, the MRI experts speak on MRI to see what they are looking for and what they should look for. On a back MRI, what they should look for, how to look for, etc. And in a knee MRI, what they should be looking for, etc. So like this, it's a slow learning process of diagnostics, history taking, and then deciding what is to be done, the plan of action. And then along the way, they also learn how important the mind is. You see, a patient may get very good pain relief, but they will deny it because they believe that their cup is permanently half empty.
Okay.
There are patients who are like that. Then there are the other patients whose cup is always half full. You give them 50% relief, they'll say, oh my, 50% relief I have had. Then the half empty cup fellow will say, I've got only 50% relief. So that matters a lot in how that patient will do later.
Yes.
So then you have to educate the patient. You have to educate the doctors also about the power of the mind. Yes. And how they have to make, convert an enemy into a friend. See, Bhagavad Gita, there is a very important quote. Manahi eva ripuhu, manahi eva bandhuhu. Means your mind is your enemy and your mind is your friend. So our patients have to be taught, your mind is a very big monkey. It will make you believe that the sun is responsible for all the darkness in this world. Believe me, they can believe that. So you have to sort of, along with the body, you have to start treating the mind also. Really difficult patients, we will of course send to a psychologist for counseling or a psychiatrist maybe. But the psychiatrist or psychologist is a faceless person to the patient. Whereas their pain doctor is more available to them on hand. So they are more ready to listen to you than to that other doctor. So every pain specialist has to learn to sort of counsel and talk to the patient. So this is like one of my students came, she was sitting with me in the OPD. She told me, इतना बोलना पड़ता है क्या मैडम? अपना anesthesia बहुत अच्छा है.
Propofol
जाता है. So इतना बोलना पड़ता है क्या? बोलना पड़ता ही है. There is no other go. So
you're teaching every aspect of pain, even the psychology of pain, not just the pain generator.
Very, very important. Yes. Because there is cerebral facilitation and cerebral inhibition of the pain pathway. So a pain of 3 can be multiplied to 6 by cerebral facilitation.
Wow.
And vice versa. I have seen people who are very calm, very quiet, very down to earth, who will not multiply their pains at all. So, in fact, in all this, it is good if you are the, the old fuddy-duddy kind, where you believe in karma and things like that, because you are passing the buck.
Yes.
Whereas the youngsters, they believe that they should control their life, or they control everything.
Yes. And also they believe in instant gratification. So the minute you put the needle in, they will feel like, okay, something is going to happen and you're going to relieve them of all the pain. But the entire circuit is not completed.
No, they are like, more than anything, they are very angry with themselves. Many of them, young patients, they say, how can I have this? Because I'm young. I'm doing everything right. How can I have this pain? So the pain is a very non-macho thing to have, isn't it?
Yes.
So he would like to be the he-man around the place. Suddenly, why is he the, cry baby here?
Yes.
So then you have to say, okay, you have to understand the body is fallible. Body can be injured,
Yes.
but you have to learn to cure it and get on with it.
Yes.
So
So you
it
actually have
is
to cure their pain as well as their victim mentality, that why is this happening to me?
many of them, many of them. And many of them will also say, ma'am, I want to run. The fellow has a neuroma sitting on his knee. He's
Hmm.
now walking, he's doing everything very comfortably, but he wants to run.
Hmm.
Okay, I have to say, okay, start running. Let's see if we can get you to a running state. So that, or somebody may want to go and climb the Mount Everest or something like that. So whatever it is they wish to do, you have to make them capable of doing it. If it
Yes.
is a realistic goal. If
Yes.
it's not a realistic goal, make him realize that he cannot do it. Allow
Yes.
him to do it, let him falter, fall, and learn that it cannot be done.
Yes.
See, nobody is going to believe you if you say it cannot be done. He has to learn it by himself that it cannot be done.
To help them alter their expectations also.
Yeah, they have to learn it themselves. So let them go and make their own mistakes and learn. That's the best teacher.
Wow, ma'am. I cannot believe how enlightening it is to talk to you, because this really opens up our mind from anesthesia to a completely different branch, completely different aspect of life. Like, I cannot even, I think I should just come to you as a patient just to listen to you counseling,
No,
because
no,
this is.
no, no, no. Don't come to me as a patient. I don't want it. But yeah, you are welcome to come otherwise.
Thank you, ma'am. So I wanted to end this on a light note by asking you, what do you miss about anesthesia, other than just giving propofol to the patient and the patient keeps quiet? Is there anything that you feel that, oh, this was what was nice in anesthesia and I really miss it while I'm practicing chronic pain?
I miss my babies. I was a pediatric anesthetist.
Pediatrics.
I miss the fooling around.
Yeah.
You see, when the baby comes, everybody in the OT is jumping and, trying to blow bubbles or blow balloons or make faces, and you become a child yourself.
Yes.
It's a fantastic, fun thing.
Yes.
So from that fun world, I had to come to this world where you see there is quite a lot of despondency, sorrow, and other things.
Hmm.
But then, of course, out of the sorrow comes satisfaction and happiness too.
Yes.
So, but I do miss being with the babies.
Hmm.
Yes. And you see, in anesthesia, you have very good control
Yes.
over most things. And
Yes.
you should have that control.
Yes.
Barring, of course, very, very unusual, unforeseen circumstances.
Hmm.
Most of the time, you are in control.
Hmm.
And I still remember doing very, very serious and severe, difficult cases.
Hmm.
And I'd be humming under my breath.
Hmm.
That's how you enjoy that control.
Yes.
But that's a adrenaline high when you
Yes.
do a very difficult case
Yes.
and you are in control.
Hmm.
In chronic pain, you realize that you have very little control
Yes.
because the control is all in the patient's hands and in his mind.
Hmm.
So you learn that you don't have control. It teaches you about life.
Yes.
Anesthesia is a make believe life.
Yes.
It's a very artificial control that you have.
Hmm.
Whereas in chronic pain, it is bare bones reality.
You have to live with the reality every day.
Yes, you have to live with
You
it.
can just forget it
But,
for
but
some.
once again, I would like to reiterate
Hmm.
that once you understand what is the real pain generator,
Hmm.
you don't really have a despondent situation. You have a lot of states, where my patients will be so thrilled, you
Hmm.
know, a 5 foot, 80 kg obese lady will be
Hmm.
coming telling me, Doc, I can stand, I can stand and do this. That's also fun. As fun as a small child blowing bubbles is
Hmm.
an old lady thrilled that she's able to stand on one leg or whatever. So you need to find your fun things everywhere.
One thing you like about chronic pain, and one thing that I would not say don't like, but don't prefer about chronic pain.
What do I like? There is nothing much to like about chronic pain, really speaking. But see, I like the challenge of chronic pain.
Hmm.
I like the new thought processes which have guided me in the right path. By the way, I must share with you, I have written a book,
Hmm.
Chronic Pain, which will be printed in January.
Okay,
It
great.
will be coming out next month.
Yes, ma'am.
Called Chronic Pain Out of Box Treatments That Cure. It's
Okay.
called that.
Okay.
And so you see, that book encapsulates my journey in chronic pain and why I went off the beaten track
Hmm.
the way I did.
Hmm.
See, and in the beginning and even now, I believe many people think that dry needling is one of those very down market kind of treatments.
Hmm.
Why would any sensible person do stick needles into patients?
Hmm.
Is their question. It's not about the needles. It's about the sophisticated thought process of what causes pain.
Hmm.
The treatment itself is anything but sophisticated.
Hmm.
You're sticking pain needles into people. But the results that it produces, how gratifying it is. And in that book, I have also detailed how I have understood the vagaries of many, many types of pains which are considered as untreatable all over the world.
Hmm.
But patients come to my clinic and get well like clockwork.
Hmm.
And that is exhilarating in itself. That is something fantastic for me, that when I see somebody who could not move their hand is useless. Some
Hmm.
of these patients are the types who will say, amputate my hand.
Hmm.
All that this pain hand does is to give me pain.
Hmm.
And such a patient, if I find that patient combing her hair and doing an ambada or whatever it is, that's
Hmm.
a fantastic feeling.
The patient
So,
satisfaction.
patient satisfaction, tremendous patient satisfaction. Or in chronic pelvic pain, interstitial cystitis, etc., or very, very severe neuropathic pains, or even in cancer pains,
Hmm.
terminal patients where they come with such severe pains in spite of maxing out on opioids and other things. If I give a Botox injection into their muscles, their
Hmm.
pains are gone. It
Hmm.
is fantastic, actually. That kind of results are just not available anywhere.
Hmm.
And just changing your viewpoint from nerves to muscles as the pain generator or the important structure in pain has done this. So all this is really exhilarating and very exciting also.
Hmm.
So that is the nice thing. And what don't I like is maybe that I'm unable to convince people that they need to look at it this way. You see, it's our country,
Hmm.
our people
Hmm.
are very colonial in their mindset.
Hmm.
Unless a white man says it, things cannot be right.
Hmm.
When someone else comes and says, don't look at the definition of neuropathic pain. All
Hmm.
neuropathies are neuromyopathies. That's what I say. So, you see, they are not ready to accept it. They don't want to accept it also.
Hmm.
So that sort of is exasperating. But now I have sort of learned that it's okay. They can believe what they wish to. When the time is right for them, they'll understand.
Hmm.
Because this is the truth.
Yes.
For the last 20 years, I have found this to be the truth. There
Yes.
are thousands of patients who have done well and gone ahead with their lives. So it cannot be a fluke. It cannot be a coincidence. It has to be the truth. So people will discover it if they are meant to discover. Otherwise, let them enjoy whatever it is they are enjoying in their lives.
Yes.
Yeah.
With that, ma'am, I would really like to thank you. I think this has been an amazing opportunity for the students to learn what to look forward to if they consider taking chronic pain as a career path, and also learning from the expert. And would you like to add any parting comments, especially for the postgraduates who are looking forward to this program?
I don't know. Maybe you should call one of the younger pain specialists and speak to them because they will give you a very different viewpoint. I
Yeah.
gave a more philosophical viewpoint, and I'm looking at solving the chronic pain problem,
Yes.
not making it into a career.
Yes.
See, you can look at success in many ways.
Hmm.
Success can be financial.
Hmm.
Success can be an academic endeavor. Success can be a satisfaction that you made a difference to somebody. So there are many levels of success. So maybe many of your youngsters would be interested in the financial success part.
Hmm.
As I did mention, I am no slouch there, but then maybe they are looking for something much more than that. Yeah.
Yes. But ma'am, I think you provided a very nice overview of the entire pain world, an introduction to it that many of us don't get, honestly, because in our institutes in India, we don't have chronic pain in the curriculum itself. We do handle acute post-operative pain, but chronic pain is hardly there in any of the institutes. So this provided a very nice introduction as well as an overview from an expert as to what should you exactly be looking at in your life rather than short term gains. What should be the long term career satisfaction that you should be looking at? So I don't think there can be anything better than that.
And I will say something very, which I believe is very important.
Yes, sir.
See, as there are a lot of intelligent people in this world, all your classmates who have taken up software, who have become MBAs, who have become that, this, whatever, the whiz kids. But none of them have the privilege of being of immense use to another human being.
Yes.
Yeah.
Yes.
And as doctors, we are utterly privileged that by doing our routine work, we influence somebody else's life, willingly, unwillingly, whatever it is. Can you imagine what kind of a privilege that God has given us to put us in this position? Just by doing stupid routine work, which you are not even interested in, but just by doing that. This is very different from a bank clerk or somebody who's a number cruncher in an MBA or whatever it is. So we should really understand what a privileged life we have been given and make the best of it and enjoy it also. Acknowledge to ourselves that we are privileged people. Isn't it?
Yes, ma'am. I absolutely agree with you. This is really the kind of approach that you get just by talking to someone who's as enlightened as you. And everyone can tell, how to make a career, how much will you earn in a particular career, how many hours do you need to work. But no one can actually.
I
Uh,
didn't say any of these things today to you.
Ma'am, exactly. So you actually gave us a reason to think what is the purpose of our life as not just as an anesthetist or as a chronic pain physician, but also as a doctor. So I don't think we could have gotten that in an interview with anyone else. I would like to thank you so much for that, ma'am.
I had fun talking to you. Thanks.
Same. Thank you so much, ma'am. Thank you.
Okay then. Yeah.
Bye.
Shall I leave?
Yes, ma'am.
Thank you.
It will get recorded then.
Sure.
It will be up on YouTube. So we'll also put a comment to the book that is coming in Jan once it's out. So I'll write the name of the book and a link to get it.
Sure.
Thank you so much, ma'am. Thank you.